All right, let's jump right into a really high-stakes clinical scenario. The kind where every single second counts. We're going to break down how you prioritize information in a crisis, using what's basically a real-world medical puzzle.
Okay, so let's put you right in the clinician's seat. You've got a patient in front of you, and they're actively bleeding internally. Their chart is in your hand, but you've got to find that one single piece of information that changes everything. So what are you looking for?
Okay, first, let's set the scene. Your patient comes in with melena, which, is a major sign of an upper gastrointestinal bleed, and they have abdominal pain. All the signals are flashing, pointing to an active internal hemorrhage. And yeah, the clock is absolutely ticking.
So you get a quick look at their medical history, and 4 things really stand out. Now, all of them are clinically significant for sure, but only one of them is the most immediate, life-threatening problem. Our job is to sift through these clues and find the critical one.
First up, we've got hypertension. Now, high blood pressure is a serious chronic condition, no doubt about it. It can definitely complicate care and put stress on the whole vascular system. But is it the reason the body's clotting mechanism is failing right here, right now? Nope. It's important, don't get me wrong, but it's not the urgent problem.
Okay, next we see Hashimoto's disease. This is an autoimmune disorder that affects the thyroid. And while it's a really key part of their overall health profile, it doesn't directly mess with hemostasis, the process that actually stops the bleeding. So we'll make a note of it, but we've got to keep looking for the main culprit.
Now what about type 2 diabetes? Now that's another major chronic illness, right? It can affect everything from circulation to how well you heal. But just like hypertension, it's not the fundamental reason this patient is bleeding uncontrollably right now. We're getting warmer, but this isn't it either. And then you see it, von Willebrand disease. Now this isn't just another complicating factor. This is a diagnosed bleeding disorder. It's a condition that is fundamentally, at its core, about the body's inability to form effective blood clots. This right here is our smoking gun.
So why does this one single diagnosis instantly shoot to the top of the priority list and completely change how you're going to treat this patient?
Well, this quote really cuts right to the heart of the matter. It says it perfectly. A bleeding disorder in a patient who is already actively bleeding is clearly the most detrimental thing going on. It's literally a crisis layered on top of another crisis.
So let's break this down. What exactly is von Willebrand's disease, and why does it take a situation that's already serious and turn it into something potentially catastrophic? Well, it all comes down to this one protein called von Willebrand factor, or VWF for short. The easiest way to think about this protein is like it's the superglue that allows platelets to stick to the site of an injury inside a blood vessel. So if you don't have enough of it, or if the stuff you have doesn't work right, that very first step of forming a clot, it just fails.
And to put that into context, it's kind of similar to hemophilia, which I'm sure you've heard of, but the key difference here is that it affects an even earlier and more fundamental step in the whole process. See, VWF doesn't just help platelets stick together, it also protects another really important clotting protein, factor VIII. So without it, the whole system is just compromised.
So, in a healthy person, the body's response is this beautiful, super efficient 4-step cascade. A blood vessel gets injured, von Willebrand factor rushes to the scene like a first responder. Platelets and other factors bind to it, and boom, a stable clot forms and plugs the leak. Simple.
But this is where all goes wrong for our patient. The whole process just breaks down right at step 2. Because there isn't enough working VWF, the platelets can't get a grip, they can't stick, a stable clot can't form, and so the patient just keeps bleeding.
So, okay, the really crucial point here is taking all this theory and knowing how to apply it in the real world. What's the lesson for anyone who finds themselves in one of these high-pressure situations?
It really just boils down to these 3 key takeaways. First, in a crisis, you have to prioritize the problem that is most life-threatening right now. Second, if a patient is actively bleeding, a history of a bleeding disorder is the #1 red flag, period. And third, you have to remember that chronic conditions like diabetes or hypertension, they're important complicating factors, but they are not the acute cause of why the clotting is failing. So really, I want to leave you with this thought. This whole exercise is about learning the difference between important information and urgent information. In any emergency, can you tell the two apart? Hypertension is important, but a clotting failure, that's urgent. And mastering that distinction, that is the absolute core of making good calls under pressure.